The topic of discussion that we are going to cover is we are going to talk about therapy for peptic ulcer, and this is the first lecture on gastrointestinal tract pharmacology. So, okay, we're going to talk about the therapy for peptic ulcer disease. Now, before getting into that, we need to understand what is peptic ulcer disease. Simply, peptic ulcer disease is the imbalance between aggressive and protective factor. Now, what are these aggressive factor? The factor that will worsen the condition of our ulcer. Right, these aggressive factors are responsible for peptic ulcer. And what are these protective factor? The factor that protects our GIT from getting what? Peptic ulcer. That is our protective factor. Simply, the aggressive factor are what? These are our HCl, these are our H pylori, right? Our HCl that is produced in our stomach, right? And H pylori, these are the microbials that are responsible for peptic ulcer. So these are what? These are our aggressive factor. And talking about protective factor, what are the protective factor? These are our mucus and HCO3. The mucus that is lining our GIT, right? HCO3 bicarbonate. These are what? These are our protective factor. Now, if there will be excessive production of these HCl, right? If there will be excessive these H pylori infestation, then what there will be the condition of peptic ulcer. Or we can say that if there will be less production of mucus or less production of HCO3, then also there will be what? The condition called peptic ulcer disease. So this is what? This is the main factor for our peptic ulcer disease. So what we can do right here is, now in order to treat peptic ulcer disease, what we can do is we can initially decrease the production of HCl, or we can we can kill a large number of H pylori, right? These microbials, or we can increase the production of mucus or HCO3. So now in this way we can treat peptic ulcer disease. So initially what we are going to discuss is we are going to discuss these HCl, right? We will initially try to decrease the amount of acid. So in order to decrease the amount of acid, right? Okay, if we decrease the amount of acid, then obviously what we are going to eliminate one of the most powerful aggressive factor. That's how we are going to treat this peptic ulcer disease. So now let's focus on one thing right now, that is HCl production. That means we are going to decrease the production of HCl. Now in order to decrease the production of HCl, we need to know how HCl is produced in body. So now the HCl is produced by what? Parietal cell. As you can see, what is this? This is our parietal cell. This is our parietal cell. And here outside what we have got? We have got lumen of our intestine, or lumen of our of our GIT. Now toward this luminal side, what we have got is we have got proton pump. As you can see, what is this? This is our proton pump. As name suggests, it helps in bringing proton into lumen. And this proton which is brought into lumen is what will combine with Cl, and it will produce HCl, and this is what? The aggressive factor we are talking about. So now our goal is to what? To inactivate this proton pump, right? Proton pump. Okay, now in order to inactivate this proton pump, right? This proton pump, what is this? This is our sodium potassium pump that is bringing H plus into luminal cell and K plus into parietal cell. So this is what? This is our proton pump, proton pump, that is our what? Our H plus K plus pump, right? H plus K plus pump. What is this doing? This is helping in secretion of acid. Now how these sodium potassium, it is what? It is our proton pump, H plus K plus pump. These H plus K plus pump or proton pump is facilitated by three main things, that is our acetylcholine, histamine and gastrin. Now this acetylcholine, which is facilitating the activation of this proton pump, is what? Is produced by what? Is produced from our this post neuron, right? Postganglionic neuron, where there is what? There is M1 receptor. So this acetylcholine is what? It is activating this proton pump through M1 receptor. Similarly, histamine is what? It is stimulating this proton pump with the help of H2 receptor. Gastrin is activating this proton pump with the help of CCK, right? Similarly, this prostaglandin E2, it is what? It is inhibiting. It is not activating or stimulating, but it is inhibiting this proton pump. That means here are how many factors that are stimulating the production of HCl. One is our acetylcholine through M1 receptor, one is our histamine through H2 receptor, one is our gastrin through CCK, right? And these are what? These three things are stimulating the production of HCl by stimulating what? This proton pump, but our this prostaglandin E2, it is what, it is inhibiting our production of HCl. So the drug that are responsible for decreasing HCl, right, decreasing HCl, how we are going to decrease the production of acid or HCl is that we are going to block these M1 receptor initially, right. That means one is M1 blocker, similarly another is H2 blocker, similarly another is our what, PGE2, what, not blocker, PGE2 what, stimulator, right, PGE2, prostaglandin E2, and another is our the proton pump inhibitor itself. That means we can directly inhibit our this proton pump also. So how many drug? One is our M1 blocker, another is H2 blocker, right. We are not going to discuss about the CCK or gastrin because we are not aware about this mechanism, and another is our what, our this PGE2, prostaglandin E2, and another is directly the drug that will inhibit what, our this proton pump. So the drug under M1 blocker, what are these? These are our pyrinzepine, right. What are these? These are our pyrinzepine and telanzepine, pyrinzepine and telanzepine. Similarly, talking about H2 blocker, what are these? These are our cimetidine, right. These mainly end with tidine, 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 right. These are our cimetidine, ranitidine, right, famotidine and loxatidine. Now one important fact, this cimetidine is not used excessively because it has several side effects, and one of them, the most popular of them, is our gynecomastia, right, gynecomastia. And this cimetidine, it is one of our this disco drug. These are what, this disco drug are responsible for gynecomastia. And from this D we have got digitalis, from S spironolactone, from C we have got what, cimetidine, from what O we have got estrogen, right. Now these disco drug are responsible for what, our gynecomastia. Similarly, prostaglandin E2, that is our misoprostol, and this misoprostol will inhibit HCl production. Similarly, directly proton pump inhibitor, what are these? These mainly in with what, these mainly in with our prazole, right. As you can see, prazole, so some omeprazole, esomeprazole, pantoprazole, lansoprazole, rabeprazole. So these are what, these are our proton pump inhibitor. Okay, now these misoprostol, these are what, these are the drug used for peptic ulcer, but these are not mainly used, but these are most specifically used for NSAID induced peptic ulcer, but the drug of choice for NSAID induced peptic ulcer is also PPI, but these can be used, right. Specific drug that is used in NSAID induced peptic ulcer are these, but the drug of choice is what, the drug of choice is our proton pump inhibitor only. So okay, proton pump inhibitor only. Now talking about what, okay, the main drug or the drug of choice of peptic ulcer, that is the one that is inhibiting what, our this proton pump, that is proton pump inhibitor, right, proton pump inhibitor. Okay, these proton pump inhibitor, they do not act locally, they act systemically. Now what does this means? Okay, once we ingest what, our this proton pump inhibitor, they will not act directly, right. What they will do is they will go all the way to intestine, and from intestine they will be absorbed into what, our this bloodstream. Now as they will be absorbed into bloodstream, now from this bloodstream they will go into parietal cells, right. They will go into parietal cell, and then they will bind with what, they will bind irreversibly with our what, proton pump, irreversibly. Okay, as you can see here, what, it is not going directly and it is acting right here. What it is doing, it is going all the way to intestine, it will be absorbed, and then it will go to blood vessel, and from blood vessel it will go into what, our this proton pump, and then it will what, it will inhibit, right, our this proton pump. Okay, so it will not work locally, it will what, it will work systematically, right. Okay, that means now as we will have what, as we will have proton pump, now here there is what acidic environment. So that means these our this proton pump inhibitor, right, proton pump inhibitor would have been would have been destroyed right here in this stomach, but it is not destroyed because these proton pump inhibitor are provided with what, these are provided with enteric coating. That means enteric coating, that means what, they are given with enteric coating. What is that enteric coating? That is acid resistant coating, right, acid enteric coating, that is what, acid resistant. Okay, now as they are acid resistant, they will bypass what, our the stomach region, and they will go all the way to alkaline region. In alkaline region, that is our intestine, and in alkaline region the enteric coating will be lost, and then they will be absorbed, right, and then they will be absorbed. Now these okay, Now these proton pump inhibitor, these are also called hit and run. Why these are called hit and run drug? These are called hit and run drug because they irreversibly inhibit what? Our proton pump. That means they will bind to what? Proton pump. Once they bind to proton pump, now this proton pump is permanently damaged, right? This proton pump will be permanently damaged. Now in order to work again, there should be production of another proton pump. Now this another proton pump, it takes 24 hours to what? To produce, to be produced. So once a proton pump is taken, what it will do is it will bind irreversibly with proton pump, and then it will what? It will get destroyed. But what? The proton pump with whom it is binding, that will what? That will not be able to generate again another HCl. So in order to produce again another HCl, there should be production of another what? Proton pump, and it takes 24 hours. Although the half-life of proton pump is what? Smaller. The half-life of proton pump is smaller, but it exerts effect for longer duration because of this hit and run, right? As the name suggests, hit and run. It will go, it will hit, that means it will bind irreversibly, and it will just go away. That means it will get degraded since it is having less half-life, but the effect will be there. That means the effect will be there to the person to whom it has hit. Okay, yes, we have already said it is irreversible inhibitor of proton pump. Example of hit and run drug: it will go, it will hit, it will get lost, but the effect will be seen. Exert systemic effect, no, it will not work locally. Yes, we talked about these things. Normally acid liable, that means it will be destroyed by acid present in stomach, so given with acid resistant coating, that is enteric coating. It is drug of choice for peptic ulcer disease due to any reason, and it is also drug of choice for gastroesophageal reflux disease, drug of choice for Zollinger and Lesion syndrome, right? Now talking about side effect of proton pump inhibitor. Okay, now since this proton pump inhibitor is causing what? Less production of HCl, that means less acidic environment. Okay, since it is causing less acidic environment, there are several things such as calcium, such as what we have got vitamin B12. These things require acidic environment to be absorbed. Since there is no acidic environment or less acidic environment, there will be less absorption of calcium, there will be less absorption of vitamin B12. That's why because of less absorption of calcium, we'll be getting what? Osteoporosis, will be getting megaloblastic anemia because of what? Less absorption of vitamin B12, and our stomach or our GIT will be more prone to infection, right? The infections because of favorable environment for various microorganisms. So talking about the side effect, yes, it will cause less absorption of calcium, causing osteoporosis. It will cause less absorption of vitamin B12, causing megaloblastic anemia. It will give rise to what? Various infections because it will provide favorable environment for various organisms, and it is also responsible for causing what? Carcinoid syndrome, right? Carcinoid syndrome, but this is mainly seen in the case of what? In the case of mice, not in the case of human, not noted in the human. It is seen mainly in the case of mice. Yes, we talked about the drugs, right? For drugs, okay, we talked about what? The drugs that are responsible for decreasing acid secretion. Now what about the drug, right? What about the acid that is already present in our GIT? That means in above case we talked about how to decrease HCl, right? But we did not talk about the condition in which there will be excessive HCl from the beginning. If there is excessive HCl from the beginning, then what we need to do is we need to get rid of this HCl, or we need to neutralize this HCl. So in order to neutralize this HCl, we have got another drug, and that is antacid, right? Okay, antacid. Now it will give a fastest pain relief of PUD, that means peptic ulcer disease. How? Because the excessive acid that is present in our what? GIT, what it is doing, it is causing pain, right? Excessive pain. So this excessive pain caused by this HCl, it is relieved by giving what? Antacid. This antacid will neutralize what? This HCl. Antacid is simply nothing but it is base, and this is our acid. So when acid and base they react, they neutralize each other. So this is the fastest pain reliever of peptic ulcer disease, and it includes what? Ammonium hydroxide and magnesium hydroxide. Ammonium hydroxide will cause constipation, and magnesium hydroxide will cause diarrhea. So since they cause opposite effect, so in market the combination of these two drugs are used, right? These two drugs are used because they counterattack each other's side effect. Okay, so this was about antacid. Now talking about ulcer protective. Okay, let's suppose there is okay, there is one ulcer right here in our GIT. Now this ulcer, on being exposed to these HCl, this ulcer will get degraded more and more, because of which it will increase the chance of getting ulcer more and more. So what we need to do is we need to protect this ulcer. That means we need to protect this ulcer from getting in contact with this HCl. So to protect this ulcer, we have got one drug, and that is ulcer protective drug, and under that ulcer protective drug we got sucralfate and colloidal bismuth substrate, right? Let's talk about sucralfate. Okay, sucralfate, but the size of sucralfate is small. Okay, let's suppose it is this much. So what it will do is, under acidic environment, this sucralfate will polymerize. That means it will increase its size, and as it will increase its size, now it is capable of protecting our this ulcer. So as I've already mentioned, the sucralfate, or let's say ulcer protective, these will work around how much pH? Around the pH that is less than 4. That means these will work in acidic condition, right? Acidic condition. So since they work in acidic condition, they should not be given combined with antacid, because antacid that we discussed just above, they are responsible for creating basic environment, or they are responsible for degrading acid. But our this ulcer protective sucralfate and colloidal bismuth substrate, these will work in pH around less than 4, right? And they polymerize at such pH. So since they require less pH, they should not be combined with antacid, right? Antacid. Okay, yes, another important point, colloidal bismuth substrate, right? These are these can cause bismuth poisoning, right? And in this bismuth poisoning, in bone there will be effect called osteodystrophy, and in brain there will be encephalopathy. So these are one important thing that we need to know. So moving further, right? And now the final drug that we need to know is, we need to know about the drug that will cause eradication of H. pylori from our GIT, and these are amoxicillin, metronidazole, clarithromycin. These are nothing but these are antimicrobial drug. Now in order to treat the peptic ulcer condition, right? Peptic ulcer condition because of H. pylori, or we can say recurrent peptic ulcer condition, we have one therapy, that is triple drug therapy. Now what is this triple drug therapy? Nothing but 2 antimicrobial agent along with one proton pump inhibitor. Yes, antimicrobial agent. What are antimicrobial agent? These amoxicillin, metronidazole, or clarithromycin, right? And one we need to add we need to add proton pump inhibitor. For example, what we have CAP. What is this? C, clarithromycin, from A, amoxicillin. What are these two? These are nothing but our antimicrobial agent, and another our PPI, proton pump inhibitor. We can use any of these, lansoprazole, pantoprazole, esomeprazole, any of these. So this was all about the drugs used in peptic ulcer disease, or therapy of peptic ulcer disease. Thank you and have a great